Hello, everybody, and welcome to the Southeastern Colorectal Cancer Consortium webinar. I'm really excited that you're joining us during, live, or after the fact, so thank you for that. We've got some really great speakers today. We're going to do 20 minutes of lecture and then 10 minutes of Q&A afterwards, so you can use your comment box if you have any questions that you would like to ask the speakers. So we are going to get started with Dr. Erica Sutton, Associate Dean for Academic Programs and Affiliations at Morehouse School of Medicine. So welcome, Erica.
Great. Good morning. Thank you. I'm going to go ahead and share my screen. Thank you, everyone, for participating and for joining us today. This morning, afternoon already, I'm going to talk about the effects of COVID-19 around health equity and who it is affecting in the South. Our mission at Morehouse School of Medicine is the creation and advancement of health equity. And so it was here that I was able to meet esteemed colleagues who do this work and who are helping to inform the country of the disparate impacts of this disease on vulnerable populations. I have no financial disclosures relevant to the content of this presentation, and that's important because I'm going to show you some sources of self-education, how you can get access to some of this data, and I don't benefit. So this was me, March 16th. The first day of work from home. I was inspired. I had drawn power from Maya Angelou and felt much like a phenomenal woman capable of teaching elementary school and administrating at a medical school. And this was me about a month later, okay, when Georgia schools were in fact going to be closed. And I realized that there is not a clear stopping point for this disease or this pandemic. And so we have to evolve, and it is time for us to evolve in this space and to figure out both who is most impacted, who needs our help most, and how we are going to prepare ourselves to deliver that help. So by the end of this talk, participants will be able to recognize those communities that are most impacted by COVID-19, find on their own sources of accurate and reliable information for disparity data, and discuss strategies for recovery and future health equity. So this was the perspective that I held when we were about 2 weeks in Dr. Teresa County in southwestern Georgia. And at that point, they had registered 24 deaths. And it was alarming because this was, significantly more. But it was also our first glimpse into some alarming data, which was of the deaths that had been registered, 90% were African American. And so the theory at that time was that this was a super spreading event. And so there had been a birthday party somewhere in Connecticut, and then a funeral on February 29th in Albany, Georgia, that had been cited as why the density was so high in this one particular area. But I think subsequent events have caused us to question that and to really identify, was it that there is a concentration of vulnerable people in that area? So the Roundtable on the Promotion of Health Equity is sponsored by the National Academy of Science, Engineering, and Medicine, and they held a webinar on April 28th. 2020. I think it's very important to add dates to some of this information, because what we know is that the information it changes and we get new information and regular intervals. And so at this, they called COVID-19 at this webinar the health inequity modifier, but I thought of it as a health inequity promoter. And that it was really sort of accelerant to some populations that are commonly disproportionately affected. And we know that this disease disproportionately affects African Americans at 2 to 3 times the rate of white counterparts. We know it disproportionately affects nursing home residents and essential workers, who are more likely to be minority, who are less likely to be able to distance appropriately. And then those with chronic conditions, diabetes, asthma, heart disease, also prevalent in minority communities, and then as well as inmates. And so I wanted to show just a little bit of data here, and I'll give you the site so that you can pull up your own colorful reports. But this shows COVID-19 deaths per 100,000 people as of May 26. And this is for all ethnicities. And you can see that the rate of about 55 per 100,000 for Black people is clearly double that for other demographics such as whites. But you could even see that there are disparities that are noted in the Latino population and somewhat in the Asian population. The difficulty here is the missing data. And at this point, we still have missing data. There's data missing here. And you'll see there's no bar for indigenous populations. So I wanted to pull our states. And so I was able to really pull out the states that are part of our roundtable and to look at what's different. I also like to mention here Kentucky and Louisiana, because in this collection, we know that Kentucky and Louisiana are Medicaid expansion states. And so this, not a statistical analysis, but an eyeball test, we really we can't confirm that there's any mitigating effect, but we do know that the access in those areas was better. Some of these states do not have data that's broken out separately for Latino populations or Asian populations. You can see in South Carolina, Tennessee, Virginia. I believe Asians are in an other category there, or maybe counted in the all deaths with known ethnicity. And so again, you'll see that our data is missing, but it is now being collected, and that's part of the CARES Act, which mandates collecting and recording of data. I wanted to talk about then the essential workers and the ability to socially distance. What I liked about this New York Times article, and they have several graphs similar to this one, but this one makes the general point, is that the top 10% wealthiest Americans are in blue, and the bottom 10% of income earning Americans are in orange. And you can see that based on location, and this is location as identified by your cell phone. So one, you do have to have enough income to have a cell phone. So, there will be some bias there, but we can see that people in the top 10% of income earners were able to remain at home and to distance more appropriately than the lowest, than the bottom 10%. I often take the term social distancing off because it's distancing appropriately, and a lot of times people aren't distancing for social reasons. They are distancing for essential reasons, such as to earn a living, to feed their family, to acquire needed food, medications, and things like that. So a lot of times you'll hear me kind of edit that to say distance or distance appropriately. And then we know this. This is some data that we also know, which is chronic conditions by ethnicity, and the Kaiser Family Foundation is generally a good source for some of this, but I wanted to pull it up because of how much it looks like what we're seeing in terms of those bar graphs surrounding the COVID-19 mortality and incidence of death. I pulled this in, this is not apples to apples, this is apples to oranges. So if you look, this is cases per 100,000, not deaths per 100,000. So keep that in mind. But, and this is from the University of Chicago, but it's difficult to get information on tribal populations and Native American groups. And so one of the things that's useful about the University of Chicago site is that you can restrict your data search by county. And so this is looking at counties that have a high percentage of Native Americans, 43 to 74%. So where to look for accurate and current information? And this has been part of what I discuss with family members and organizations and social group, which is how to educate yourself so that your only sources of information aren't social media, so that even you have the opportunity to get information beyond just, you know, cable news networks or national news networks. And so I'm really kind of sharing some of the sites and sources that I found as I was listening to webinars and educating myself, and then looking specifically for data on the impact of coronavirus by ethnicity. So this is the APM Research Lab, and they have the opportunity to sort and pull through lots of data. I also like the New York Times, you saw some things there. They're usually going to have a primary source, and so it's good summary data, but a primary source is often referenced. I encourage you to follow through with that. This is the University of Chicago site. It is their US COVID Atlas, but it's the Center for Spatial Data Science. And it was where I was able to pull data by counties and find counties that have large Native American regions. And so you can see that this actually, the graph that you're looking at from Sunday is new cases. So the more red, the more new cases those areas are showing, and way to go, Kentucky. And then I like Kaiser Family Foundation. I've liked them for a while for some source of healthcare information. I do, you know, sort of caution. I actually like my science unbiased, and they have a liberal bias. And so if you just want data, it's a great source. And then if you want, you know, if you want a little more editorializing, you can kind of read their articles. But I think that as a data source, you can get a lot of good information from KFF. And you're looking at a graph that's just showing the percentage, the Black percentage of cases. So of all the cases, for example, in Georgia, the percentage is between 31 and 57%, if you're looking at that. And then the last two resources that I just think are good for up-to-date and daily information. I didn't think that they were specific to good ethnicity data, but it has been good data about the coronavirus in general. And that's, of course, the World Health Organization website, and they have a dashboard. You see a smaller version there that's useful. And then the CDC, and the CDC does weekly webinars that you can tune into and listen to. And really, they offer some amazing information. They really talk about some of the first cases that they knew of Americans abroad. You know, pilots and things like that, even as early as December and January, and kind of what we know now. For the last part of this talk, I want to pull a quote from Dr. Stephen Thomas, PhD and director of the Maryland Center for Health Equity. And what I like about what he said was that it was hopeful, that whatever we build on the other side of this thing, it has to be better than what we had before. And it's to say that we're not just really trying to get back to some baseline or some normal that existed for us before March 13th, March 16th, 2020, but that we really should set as our target to build something that was even better. And so I want to talk about the impact to community health centers, because I want to talk about where we're going to have to get to that's even better. So annually at our nation's community health centers, 28 million people are served. And we know that over 90% of them are low income, and well over 60% identify as being a part of a racial or ethnic minority. And this is really what they're seeing, which is whatever we think we're seeing in our hospitals and clinics. It's doubly so in our community health clinics. So 127,000 tests with 36,000 positive tests. So almost 1 in 3 people getting tested in the community health centers. And that's roughly double the national positive rate for this same period. And so that burden of disease has its toll because there has been a precipitous decline and in the volume, and there's been the need for some of the health centers to close temporarily. And so this map shows the percentage of health centers that have had to temporarily close as of about a month ago. And some of those are able and beginning to reopen, but you know, correlate that with Alabama, Georgia, Mississippi, areas in which there were higher percentages of African Americans who would need these services. And the future challenge for the community health centers has been financial stability because of the precipitous decline in volume, but also a real concern from a workforce perspective. So closures and the risk of delivering healthcare is going to challenge the available providers who will contribute to the workforce to keep these community health centers open. And then lastly, a piece of good news, which was we know that we're making a difference in colon and rectal cancer. You know, that the disparities are present, they persist, particularly among the uninsured, and progress for colorectal cancer screening only. So we have to stay in the fight, and we have to keep up that fight. Because what we've seen is, in the faint gray line right here is January. We see spikes at the end of the year. And in the faint gray line is January. And so we were about where we are about in January until we stopped doing all quote unquote elective procedures, and urgent and emergent cases do continue. This drop is estimated to be about 86%, but perhaps even upward 94% for all cancers combined. Colon and rectal cancer screenings are right here. And so NCCRT combined with the Colon Cancer Alliance to really have a webinar in which 4 statements were made, which encouraged, you know, talking to a provider about the appropriate colon cancer screening for you, because we can persist in screening for colon cancer during this time with DNA and stool-based studies. So what is it that we must do to get back to not just that baseline, but to this better than baseline? And what are the precautions that we need to adhere to as we return? Well, there have been research, and there are no additional recommendations required for our endoscopy suites. There are no additional recommendations for the processing, handling, or storage of endoscopic equipment. Of course, we want everyone to wear personal protective equipment. That is still important and very important in our healthcare settings. Consider spatial distance and flexible schedules for staff, such that perhaps the density of staff is not as high. And clean the room thoroughly. And these were all things that, you know, you'd like to think that we were doing before, and now our health is even more incumbent that we do them well. And then the last thing I have to add, because staying healthy mentally has really been the current challenge for providers across the board. You know, I mean, equal to burnout before COVID-19, which is staying healthy mentally. We know that people are managing practices that have perhaps seen no income for 3 months out of the year. They are likely managing a home work environment that includes non-paid, unofficial employees in the form of spouses or children around at all times. And then the uncertainty of what there is to go back to. How do you go back to that? How do you stay safe, keep your family safe? And then frankly, we all have vulnerable populations that we either know, taking care of, and have to be concerned about. And so I'm asking everyone that amongst what we must do is stay healthy mentally, so that we are ready to build that better version of our work environments. And thank you so much. I'm grateful for the opportunity to speak, to have this conference in a form, and I look forward to seeing everyone next year in person, I hope, in June 2021.
Thank you, Dr. Sutton. The chat box is open if anybody wants to ask some questions to Dr. Sutton right now or make any comments. I see a couple of you guys have already used it. It looks like we've got, Debbie said earlier that Virginia also expanded Medicaid. That was earlier on in your talk.
Oh, yes, yes.
So any questions, I'll give you guys a second to go ahead and ask anything or make any comments.
Yeah, if I can ask while we're picking those up from the Q&A box, not the, you should send them to the Q&A box, not the chat box. But Erica, how do you think we're going to need to reimagine colon cancer screening, given how far we're falling behind right now, and also the need to really shoot higher? I mean, colonoscopy clearly has a lot of challenges. Can you tell me how it's looking from your standpoint in the clinical space?
It's going to be imperative for a few reasons that existed before COVID-19 that we are doing non-invasive screening. And that's because the volume of people who we need to screen, the unmet need, early age onset, colorectal cancer is becoming, having an increasing incidence. And so I really think that if we think about this, this is forcing us in the direction that we needed to go, that we should be going. And it's just a push in the back of at least the place where our faces, our eyes were already pointed, which is more non-invasive means of screening. I think that's also going to be incumbent upon us to do a better job with just the history taking portion of our screening and family history gathering. You know, one of the things that I did with our, nearly 400 medical students is set them out to go get histories, just, calling and checking on people who might be afraid to come out of their homes and some of our, vulnerable populations who normally we would see in clinic. And so we had to set them to the task of engaging communities and taking more detailed history and getting at that end. So this is, again, think of it as an opportunity to run in a direction that we needed to go, which is more detailed history, more history taking, use of telemedicine to get non-invasive screening tools that can be delivered to the home. So when I think of it that way, I feel a little more optimistic. I feel encouraged, and I feel like, well, good, we needed to do this anyway. I looked at the chat. I'm looking at one question in the Q&A. Should age of first screening be moved to 45-year-old for African-American men? So, right now to the American Cancer Society, that we would say, yes, USPTF has not moved up, but there's absolutely no African-American men in my life who I would let get past this important point, okay, for their screening. If you care, you force them to screen, and I'll tell you, no, they don't necessarily want to go right away, but I think that everyone, when they've heard not just my cajoling, but also testimony from African-American male survivors and previvors who have had their precancerous lesions removed based on being forced to do screening through identified family risk and things like that, then it is an easier argument. And so I joke with my friends, I'm handing out black cards. If it means that you will screen these vulnerable populations and you will encourage African-American men at the age of 45 to get their first screening, yes, please do.
We do have one other question that's in the chat box. Hello, Dr. Sutton. What do you think the best approach is to involve community health centers to increase colorectal screening rates?
Hello, it's from my very good friend and colleague, Dr. Rhonda Henry Tillman. And so, community health centers, in order to help them with their screening, there have been some wonderful programs and partners, but we've said that they have a lot of patients who are low income. And so I encourage anyone who can and does and can operate a scope to participate in programs that help increase colonoscopy, help increase access to non-invasive testing. And so if you work in an OR, if you work in a surgery center, talk with the surgery center as part of your mission being having a partner who's an FQHC. That would be ideal, I think, because they have patients with positive non-invasive tests who desperately need to have a diagnostic procedure. And so diagnostic therapeutic, I really should say, procedure done. So be a resource to those community health centers so that they can increase their colon and rectal screening rates. And I saw a few more questions I think popped up in Q. Hi, Dr. Hotz. Yes, I was referring to Albany. Do you want to read these? Do you want me to read them, Amanda? So Dr. Hotz is in Albany, and he is a part of the steering committee for NCCRT. And he says, from Albany area primary care, our CHC was hit very hard, and over 250 positive COVID, 38 staff, and 1 died, 2 staff. Most came from exposure to patient at super spreader event at the funerals. But 10 of 20 of our administrative offices came down with COVID. Highly infective virus, must maintain precautions, and need to start surveillance. So very, very important and on the ground insight as to its spread in Albany, Georgia.
Let's see, I think we've got time for one more. Can you explain a bit more about no additional recommendations for colonoscopies? Is there evidence of COVID in stool? And if so, do precautions need to be taken to reduce spread?
So it turns out there is evidence of COVID in stool. And then the evidence that we have is that the current precautions, when you sterilize scope with our current processing, handling of scopes, storage of scopes is sufficient. That plus PPE is sufficient. So I don't want my words to be taken as you don't need to be careful. You do need to exhibit extreme caution. What we have found is, yes, risk from stool, but our current precautions, when used correctly, are protective. And Amanda, if I can just indulge in one quick question from Mary Dorshank, who said, what does reopening look like? And I want to talk about that because, you know, my organization has been an early, you know, first the state of Georgia was an early opener. And I've noted that we're in phase 2 longer than some areas, but part of that is because for us, reopening has meant getting a lot of data. And so getting tested for COVID-19 and making the accommodations for spatial distancing in our work environment, as well as staggered schedules for arrival. And so, and Mary's question was about, can you talk a little bit more about trends in FQHCs and what does reopening look like? That's going to look like, and I'll tell you, you know, we had a plan, and then as we got closer, we realized our plan needed improvement. And so it took us about 4 weeks to plan to open an organization of about 1,000 people. We've had a 4-week, very slow spread. We haven't brought our students back into that space, but we are making our plans to do that. And so what I could say is that reopening looks like a lot of planning, a slower than you expect, you know, kind of re-entry. And we're still at maximum about 80%. So we do every other day, and everyone's virtual still on Fridays, you know, and we're having to figure out that there are some things that have to be done in person. And so how are we taking precautions to reintroduce those skills and things like colonoscopy that has to be done in person? And so the utmost of protection, PPE, and having resource and supplies for those has been part of our planning, is that we have to have enough supplies for our in-person activities. Okay, and then I will stop because that's my 2 minutes.
That's okay. I'll just read this comment really quick before we move on from Annie. She says, thanks, Erica, great talk. When we are talking about non-invasive CRC screening options, we need to discuss at the national level how we are going to stress risk assessment with PCP in patients so that we don't fall into the pattern of selecting screening due to feasibility of certain screenings rather than selecting based on risk management. Also, we are discussing a priority listing of patients, highest risk, diagnostic versus fit, positive to determine the priority of colo scheduling.
Thank you, Annie. I think an excellent point to make sure that the right screening test is selected.
Thank you so much, Erica. We really appreciate you.
Thank you. I'm muting.
And next we have Jordan Carlitz, Associate Professor of Medicine at Tulane University.
Great, thanks, Amanda. So I guess we can advance the slide. Thanks for presenting the slides for me.
Absolutely.
We're going to be talking about telemedicine, focusing on telemedicine before, during, and after COVID-19. Perfect, thank you. Okay, so we could go to the next slide. So I do have some disclosures. So I'm an advisor for Exact Sciences. I'm also the Chief Medical Officer and Director of Clinical Operations for GI On Demand, which is actually a GI-focused telehealth platform. So that we help develop in partnership with the ACG. Okay, next slide, please. So I'm going to give an overview of what I'm going to be speaking about today. So I'm going to talk about the basics of telemedicine. We really need to understand that just so we know what changes are going on with COVID, particularly with regard to policy changes, and also to try and understand some of the clinical impacts of COVID-19 that also may involve policy changes. And then finally, I'm going to end with how we approach colorectal cancer screening in the setting of COVID-19, and really how telemedicine can play an integral part in improving colorectal cancer screening. So next slide. So just by way of introduction, people may know some of the basics of telemedicine already, but I am going to go through some details because, as I mentioned, I think it's important for people to understand the terminology. So telemedicine is the application of information and communication technologies for providing healthcare services at a distance without the need for direct contact with the patient. So prior to COVID-19, telemedicine was really used quite sporadically. You wouldn't really find many people that were using it consistently throughout the week. But with that being said, in 2016, there were more telehealth sessions conducted than in all previous years combined. And then in 2017, that number doubled. But it has still, at least prior to COVID-19, it's still been really used sporadically. Okay, next slide. So after COVID-19, or in the very beginning during the first few weeks, there was actually a 4,000 increase in utilization of COVID-19 just in a few weeks, which is really amazing. That's an amazing number. That's really years of use crammed into just a few weeks. So it's really a crash course for practices to utilize and learn telemedicine. And now it's really critical to maintain clinical practice volumes, particularly in high COVID-19 burden regions and areas. Okay, next slide. So some of the key terminology that you really should need to be familiar with. So there's a difference between telemedicine and telehealth. Telemedicine is really that real-time audio-video connection you have with the patient, whereas telehealth is more of an umbrella term that involves different types of communications between patients and providers. And then there's something called an originating site, and this is where the patient is located during a telemedicine visit. And this comes into play because there are policy changes that have expanded the originating site qualifications for patients. This originating site could be at home, or it could be in a local physician's office or provider's office, and it could also refer to the state where the patient is located. The distance site, on the other hand, is where the provider is located. So that could be in if you're doing telemedicine, you could potentially do this from your own home as a provider or in your office, and potentially even in another state, depending on interstate licensing. Okay, next slide. Then there's some other terms you may see. There's something called synchronous care. That's really real-time exchange of information. So an audio-video interaction between a patient and provider. And there's something called asynchronous care or store and forward. And that means you have information that you collect and then you use it in the future for a future evaluation, like potentially for a specialized consult that may be placed and done at a later time. And this is important. There's something called a parity law. So these are state-specific laws requiring that commercial insurers reimburse for telemedicine in a similar fashion to an in-person visit. That does not necessarily mean that there's complete pay parity, meaning that it may not necessarily be exactly equal to an in-office visit. Although with COVID-19, there's actually a push to ensure complete pay parity just to facilitate interactions between patients and providers. Okay, next slide. So there are a lot of benefits for telemedicine. Some of them we may not actually think of. From the patient side, there are a lot of costs that are involved for a patient to go to an in-office visit that sometimes the provider doesn't actually consider. So there's transportation to and from visits, childcare expenses, and lost time from work. These are just a few of the things that could be barriers for patients to see providers in the office. And those are a big deal. Those could add up to hundreds of dollars, hours of missed work. Telemedicine could also allow for more frequent check-ins with the provider with chronic conditions. So this may not necessarily happen if a person has to come to an in-office visit all the time. And importantly, telemedicine is really well accepted. 70% of millennials and others actually prefer a televisit over an in-office visit. Okay, next slide. There are also a lot of benefits for providers. It could allow a provider to customize their daily schedule. So if they're busy during, if they need to free up business hours to do personal tasks, or things related to their family, they could potentially shift patient interactions to after hours or even on the weekends. And from the patient side, again, it really allows providers to take better care of their patients because they could check in more frequently with regard to chronic conditions like IBD, diabetes, etc. And importantly, it may actually help alleviate provider burnout, which we know is a major issue, because it gives providers more plasticity to their schedule, and it really frees them up and allows them to have more control about what they're doing in terms of interacting with patients. Okay, next slide. So does telemedicine work? It definitely does. I cited two studies. I'm a gastroenterologist, so I cited two studies that are in the GI world. So there was one IBD study recently that was published in the American Journal of Gastroenterology that showed that patients are receptive to telemedicine and that it could actually decrease IBD-related hospitalizations. And then there was a similar study in hepatology, which showed that it could actually improve mortality among patients with liver disease by incorporating telemedicine into practice. So there's definitely objective studies out there showing that it works. Next slide. So key issues in telemedicine, which are all impacted by COVID-19. I'm going to go through these quickly. So there's licensing, malpractice coverage, reimbursement, billing, coding, and technology issues. And again, all these could actually play into colorectal cancer screening. So next slide. So licensing, so this is the provider license. In most states, this is usually covered under the full professional license. But for interstate licensing, you may need to obtain a special licensing for a neighboring state if you're located in one state and the patient is located in another state. So that might be the case in New York, for example, if you're seeing patients in New Jersey. However, many states now participate in interstate licensing and the application is actually facilitated, particularly in the setting of COVID-19, making this a lot easier. I should say that the majority of states recognize eligible telehealth provider types, not just physicians, but also nurse practitioners, physician assistants, nutritionists, et cetera. So it's actually really easy to use telemedicine. Next slide. For malpractice, this really varies among insurance carriers. Some carriers include this, others require a rider, but it is actually pretty easy to obtain. Next slide. And then for reimbursement, this is important, again, when we start talking about colorectal cancer risk assessment. So you really want to divide this into the three main payer types. There's Medicare, Medicaid, and private payer. Next slide. So for Medicare, specific to traditional Medicare, coverage usually didn't include the home as an originating site. So remember before on the prior slide, I was talking about these originating site restrictions. Before COVID-19, the patient could not actually be in their home for a telemedicine visit under Medicare. So that's a major barrier. But fortunately, there have been some lifting of these restrictions, making it a lot easier for patients and providers to interact. Next slide. This is actually the document, the CMS document that lists, I know the typing is small, you don't necessarily have to see it, but those are the lists of qualified sites before COVID-19 that patients would need to be at for the originating site, and the home was not one of them, but now it is, fortunately. Okay, next slide. For Medicaid, as we know, these are federally funded programs, but they're state administered, and so coverage varies by state. But unfortunately, an increasing number of states are dropping originating site requirements. Next slide. And then for private payer, there's really a lot of heterogeneity in this, obviously, because within a given state, there could be multiple private payers, and they could all have different ways that they are dealing with telemedicine. So as I mentioned before, there are state parity laws that ensure commercial insurance coverage is paid, is reimbursed, excuse me, but remember, this is not always complete pay parity, and this is going to vary by state. And what we recommend is that providers directly contact private payers to assess for restrictions in payment rates. And then there's actually, on the next slide, you could see the slide showing in 2020 the US parity map. So you could see that 42 states now have laws in place requiring that telemedicine be reimbursed to some degree by commercial payers. So that's really good news. If you looked at this slide maybe 5 years ago, there would be much less gray. But now you could see that it's almost basically filled in. And even in the states that don't have laws in place, that does not necessarily mean that there won't be some form of reimbursement for telemedicine. Okay, next slide. So for billing and coding, we get a lot of questions about this, or I frequently hear about this. So a physical exam is obviously not required to bill for telemedicine, but you can do a virtual physical exam to assess the patient. You can see how they look, what is their mood like, their affect. And importantly, you still need to meet appropriate time-based or evaluation management-based requirements for you to bill, just like you would in office. And importantly, there are certain modifiers. We don't need to get into the details here, but there are certain modifiers that you have to place on your billing code in order to get reimbursed for telemedicine. Okay, next slide. And technology, I think this is really important to talk about. Again, we're going to kind of shift this into colorectal cancer screening soon, but you have to understand that there are multiple steps that may be involved for patients and providers to interact with telehealth, and each of these steps could lead to a barrier. So, of course, you may require a computer with a camera and microphone to interact with your provider. However, sometimes you could use a smartphone. With a smartphone, the process is usually quite simple, but it may you may need to respond to a text message, or you may even need to download an app. So patients and providers both need to know how to do that, because sometimes providers can actually conduct the visit on their smartphone as well. Okay, next slide. Availability of appropriate internet services and technological competence, those are obviously going to play a key role. And importantly, in some areas, internet access and speed may be a limiting factor. So we may take this for granted, some of us living in larger cities. But in some more rural, remote areas, internet access and speed may actually be slower, and it may make it hard for patients to interact with providers. And then obviously you need some degree of technological competence in order to navigate these virtual care platforms. And importantly, we really need to be asking about our patients beforehand if there are any limitations that we can help overcome. Okay, next slide. So now I'm going to kind of shift into COVID-19 policy changes, and I think these are important. So I kind of gave you a background. I know that was a bit long, but I think the terminology helps people understand what's involved. So a number of things have taken place over the past few months. Number one, there's been reductions in the burden on multi-state licensing requirements for out-of-state providers. So that makes it easier for a provider in one state to interact with a patient in another state. There's also been a move to increase reimbursement and increase recognition for telemedicine services across insurance carriers. So again, this is all making it easier for patients and providers to interact. And there's also been a relaxation of HIPAA rules. So you can see here on the bottom that the Office for Civil Rights stated that they will not impose penalties for non-compliance with the HIPAA rules in connection with the good faith provision of telemedicine services using non-public facing audio-video communication products during the COVID-19 emergency. So to translate that, that basically means that you don't necessarily have to use a standard telehealth platform in order to interact with your patients. You could potentially use Skype or something like that. Okay, next slide. So possible modalities that may be able to may be used during the pandemic include Apple, FaceTime, Zoom, Skype, etc., but not public-facing modalities such as TikTok, for example. So before COVID-19, there was no way that you're going to be able to use these modalities. But now with COVID-19, it's really opened up and allowed patients and providers to really interact quite seamlessly through a lot of these different platforms. And another thing I should say is that if a patient does not have a computer, smartphone, or internet connection, the provider may actually be able to talk with the patient over a simple telephone call and get reimbursed for that as well. So again, a lot of these are changes due to COVID-19, but we don't know how long they're going to last. So you have to kind of continually check regulations to see what's happening with that. So some of the clinical implications of COVID-19. So obviously in-office visits decreased substantially. This was already mentioned. This is to protect patients and providers from possible infection. And importantly, virtual care could fill in these gaps. It could preserve patient flow, not just for pre-existing patients, but even for new patients. And importantly, for procedure volume, we've talked about this before, or it was already mentioned before in the prior talk, that procedure volume in many areas, including screening colonoscopy, is incredibly low. And the reason for that is we've had to shift our focus to urgent and emergent cases due to endoscopy issues where we just can't do the volume that we could do before. And this is related to PPE availability, high COVID-19 infection rates in many areas with extensive community spread, which may imply that for every patient that you scope, even if they're COVID negative, because there's a risk of a false negative, you're going to have to be masked up potentially with an N95 mask and even more PPE. So this really limits the amount of testing that we could do, and unfortunately has led to a shift away from screening. And importantly, there are many endoscopy unit precautions that also affect procedure volume. And this includes like terminal room cleaning. So if a COVID positive patient is scoped, that room needs to be terminally cleaned, and that could take 30 minutes to an hour, and that could really decrease room turnover time and prevent the next patient from getting in quickly. So all of these things work together to decrease the amount of procedures we could do, which is certainly going to have an impact on screening. Okay, next slide. So chronic disease management in the setting of COVID-19. So this also applies to prior. As already mentioned, telemedicine, we're going to kind of shift back to telemedicine. This really could help in terms of managing various diseases. These are mainly GI diseases, again, because I'm a gastroenterologist, but many other chronic diseases can be managed through telemedicine. For GI, IBD, irritable bowel syndrome, et cetera, these are all very amenable to telemedicine. Next slide. And then in terms of, to focus a little bit more on GI procedures again, and again, related to colon cancer screening, the way that we could use telemedicine, and the way I use telemedicine, is to assess patients for concerning symptoms that we might not be able to get. We may not be able to get that information if we're not checking in with them and they're not coming in into the office to be seen. So for example, if they're having rectal bleeding or abdominal pain, or they have abnormal test results like a positive stool test, or they're anemic or abnormal imaging. All these things could help us decide whether or not a patient needs a procedure. So there's the risk stratification for the need for procedure, for example, colonoscopy. And then the second part of this slide is the timing of the GI procedure. So how long can we wait to schedule this procedure? For example, is there a concern for cancer? Colon cancer, is there concern for other things? So, outside of colorectal cancer, like a bleeding ulcer or things like that. And again, the timing of the test is going to depend on how urgent you think that patient needs to be evaluated, balanced with your specific endoscopy environment. So how much PPE do you have? What's the room turnover like? How many people are testing positive for COVID in your area? Next slide. So in terms of colorectal cancer screening specifically in COVID-19, there's not actually a lot on this that's been published in the past few months. I'm sure there will be, but obviously, COVID has only been around, or the pandemic has really only been increasing in acuity over the past few months. So we may expect to see literature on this arise, going into the summer. But there was this one paper that was published in, it was actually written up in the JAMA Health Forum that talks specifically about colorectal cancer screening and COVID-19. And in that forum, in that JAMA Forum piece, they say, they talk about the fact that 23 million adults aged 50 to 75 are past due for screening, and that an estimated 53,000 Americans will die from colon cancer this year. And they also talk about the fact that adult PCP and GI visits have dropped by 49% and 61% respectively. And that's since the Centers for Medicare and Medicaid Services recommended to delay non-urgent issues starting in mid-March. So that 61% drop in PCP and GI visits is critical because primary care doctors are really instrumental in arranging screening or ordering screening, and GI providers are, obviously instrumental in doing the colonoscopy if that's the kind of testing that was ordered. This has massive implications for colorectal cancer screening. And I think we really have an opportunity to use telemedicine in this setting. So that 61% drop in GI office visits and 49% drop in PCP offices, pretty much all of those could be converted into telemedicine. And that allows us to discuss symptoms, to risk stratify patients by family history, and to see what kind of testing they need. So could we convert patients to stool-based testing if they're average risk? What is their family history? Do they have a family history of colon cancer that would make them eligible for earlier colonoscopy? And what kind of symptoms are they having? Or is this really a screening test or is this a diagnostic test? Next slide. The other issue is that if you end up doing stool testing, for example, if you do a telemedicine visit and there's no family history and no concerning symptoms, and a test is positive, we need to make sure that there's a clear referral process in place for diagnostic colonoscopy. This could be a major barrier to getting people to, it's hard enough even before COVID-19 sometimes to get people with a positive stool test to get them to colonoscopy. But with COVID-19, there could be even more barriers. And the reasons being is that local GIs, they may not be doing colonoscopies, or if it's for a positive stool test, maybe there's a long wait period because they're busy doing people with bleeding ulcers or things like that are emergent and need to be done within the next few days. So obviously a positive stool test, you want to do it very quickly, but there may actually be emergencies like food impactions, bleeding, things like that, that may actually come before doing a positive stool test. So I think the best thing to do within communities is to facilitate communication between the people ordering the stool test and the GIs or whoever's going to be doing a colonoscopy if the stool test is positive, to make sure there's seamless communication and that you don't have somebody with a positive stool test just kind of hanging out there because you can't get them into an endo unit. So next slide. So to conclude the talk, so historically, as I mentioned, telemedicine was being used, but really sporadically. But since COVID-19, there's been a 4,000 ramp up in utilization, which has really led to a crash course in how to use this technology. Telemedicine is now a necessity in most practices to maintain clinical volume and contact with patients. And there are many, many policy changes due to COVID-19, but it's really unclear how long those are going to last. So for example, we talked about using the telephone and billing for that, and relaxation of HIPAA requirements where you may be able to use Skype, for example, to interact with patients. But we need to pay close attention to how long these relaxation and requirements are going to go on for. And importantly, we have to think, creatively. How can we use telemedicine for colorectal cancer screening and to risk stratify patients for earlier screening? So we need to think about this consistently for family history, assessing symptoms, and discussing options with patients to go forward with either colorectal cancer screening or diagnostic testing. Thank you.
Thank you so much, Jordan. I know, amazing job. If anybody has any questions, go ahead and put them now in the Q&A box.
Yeah, it was kind of a decent amount of information just because I wanted to give the basics of telemedicine so everyone could kind of understand the COVID policy changes. But yeah, if there are no questions, you could always email me or.
It looks like we do. We do have one from Keisha. At some point in the future, when it is believed that the pandemic has subsided, do you believe that payers will again increase restrictions where telehealth, telemedicine is concerned? I certainly hope not, since there's so many benefits, and some of us in rural areas have been proponents for this for some time.
Yeah, that's a really good question, and it could depend on the environment, which payers we're talking about, if it's Medicare or Medicaid or commercial insurance. I think that this ramp up in telemedicine really showed the benefits of it for both patients and providers, and I'm hoping that a lot of these relaxations and restrictions will persist. even after COVID-19, but it's unlikely that all of them will persist. For example, like, just using a simple telephone to conduct, I'm not sure how long that's going to last. But the fact that so many people have had to use it now, like I said, it's been a crash course in the technology usage. And I think that's made everyone more comfortable using telemedicine. And so I think it's really here to stay. And I think more people are going to use it even when the COVID-19 pandemic abates. I think it's going to be used much more frequently. And I think a lot of these policies are going to facilitate it going forward.
And that's kind of what Allison says too. She says, any plans on work on policy related to keeping certain aspects in place?
Yeah, there was already a move towards interstate licensing relaxation before COVID-19. And I think that's important in rural areas because there may be a city that the closest city may not even necessarily be in your state. That can apply for within a state as well. But interstate licensing relaxation requirements has been a movement even before COVID-19, and I'm sure that that's going to persist. But I think some of the key issues going forward are maximizing reimbursement for providers. That really needs to be done. So not just having parity, but having complete pay parity, as I mentioned before, meaning where the in-office visit is reimbursed $1 for $1 with a virtual visit. I think that is a really key thing. Making it easy for providers to have malpractice coverage for this, and then facilitating some of the technology, potential technology barriers on the patient side. I think all of these could be, will be really helpful, and I think there will be a movement for that going forward.
And then we have one comment from Jim Hott. He says, well, I just lost it. We are now being told that FIT are on back order at some commercial labs. Or back order, some commercial labs caught up with COVID testing. Anyone else having this problem with FIT being on back order?
Yeah, that I can't really attest. As a GI provider, I mainly do colonoscopies for a positive stool test, so that I can't really comment on. I haven't heard of that in Louisiana, but that doesn't necessarily mean it's not happening.
Okay. It looks like you do have another question from Annie. Jordan, in your discussions with Mark, do you know if ACG is looking into making national recommendations to establish general timing guidelines between recommended time frame between FIT and follow-up colonoscopy?
That I do not know, but I could try and find that out. I mean, that's a really good question, particularly with what I was saying before, that some of these endo units are really, their volume is so much lower. Their ability to do cases is so impacted by COVID that it's hard to get patients in a timely fashion. And what we've really been doing is tiering patients. So I recently went through my entire endo list, which was like several hundred patients, and I assigned them a tier. Like tier one was like, this needs to be done within a few weeks. Tier 2 is this procedure needs to be done within 2 to 3 months, and tier 3 was like, could be done in a year. And this isn't just for colon cancer screening, this is for everything. This is people with epigastric pain, nausea, and vomiting. This is people with dysphagia, which means, food getting stuck when you're swallowing. So all of these different GI disorders are kind of jockeying for a spot in these procedure units. And so, even people with positive FIT tests and things like that, they need to, there's this almost like a competition to get these procedures done quickly. But I know the GI people are working as hard as they can to tier people and get people in as quickly as possible. But to kind of circle back to that question, I think guidance nationally would be helpful to try and figure out how long it would be safe to wait. Although there have been some studies on that before, but some support from the national organizations would be helpful. Any other questions?
There is one last question. If people keep asking you, you can always go in the Q&A after and answer those. But one person, John says, what is your algorithm for a patient with positive stool test for whom colonoscopy is not feasible?
Well, I hope to not have to use that algorithm because I always want the colonoscopy to be feasible. And so as I mentioned, as a GI doctor, I'm generally not ordering stool tests, but I'm seeing the positive stool tests. And I'm trying to get those done as quickly as possible. So I would hope there wouldn't be a case where the colonoscopy would not be feasible. And I'm not sure in that question whether that means that there's a patient factor where it wouldn't be feasible, like if they're too sick or, you know, from comorbidities, or whether it's a logistical issue getting the person into an endoscopy unit. But from my perspective, I put a high priority on these positive fit tests, and we try and get them in very quickly for procedures.
Okay, thank you so much.
Thank you.
And then a couple more people are still asking questions if you want to get in that Q&A box. You've got a lot of questions in there.
Okay, yeah, let me see. Okay.
And
Okay, great, thank you.
Oh, thank you so much. And we will go ahead and move on to Rebecca Siegel, MPH, Scientific Director, American Cancer Society.
Hey, I actually have a question for Jordan before I get started. If I could, I was wondering if you think that more telemedicine could contribute to more delays in diagnosis for early onset patients.
I think that it kind of depends on how aggressive we are about using telemedicine. I think that we can't forget about the early onset patients, and if the providers are kind of aggressive about making sure they check in with those patients and risk stratifying them based on a virtual interaction, then I think that could actually decrease the risk for these patients. But if we're kind of not focusing on that population and only using telemedicine for like people with Crohn's disease and, you know, with active symptoms and things like that, then I think it could be, you know, potentially detrimental. But I've been pushing, you know, people that I work with to make sure that they, you know, take symptoms seriously in young patients and check in with them with a virtual encounter, you know, make sure they, you know, we check their labs and, you know, stratify them for procedures. But I think that it could certainly help for sure. But if we're not using it in that patient population, then obviously that would be detrimental. But I think if it's used properly, it could actually improve things.
Okay, thanks. All right. Okay, can you see my slides?
Yes.
Okay. Hello again, everyone, and thank you for joining us today. And I'm gonna take a little bit of a turn here with the topic and talk about epidemiologic characteristics of colorectal cancer occurrence before age 50, which is often referred to as early onset colorectal cancer. First in the US broadly, and then down a little bit to the 12 states in the Southeast. And along the way, I'll point out some opportunities for mitigating the burden, mainly through screening, while we await research to determine the cause. So overall in the US, colorectal cancer incidence and mortality has been declining rapidly for several decades, as most of you know, because of changing patterns and risk factors, as well as increased screening and for mortality improvements in treatment. Of course, these trends are driven by cancer rates in the oldest age groups who have the highest rates and mask rising incidence and mortality among younger individuals. This slide shows incidence trends for people under 50 on the left and 65 and over on the right from 1995 to 2016. As opposed to the longer term trends that were shown on the previous figure, this slide and the remaining trend figures are based on a data set that reflects almost 100% of the US population, but it's only available as of 1995. Incidence rates have actually been increasing in people under 50 since the mid-90s by 44%, while simultaneously declining by a similar magnitude in those 65 and over. And mortality rates, which are available long-term for the entire population, have also been increasing in those under 50 since 2004 at a slightly steeper pace in men than in women. And this is in contrast to the more similar slopes for incidence and may reflect earlier diagnosis in women. 36% of women are diagnosed at a localized stage disease and versus 31% of men under 50. Among middle-aged individuals 50 to 64, incidence and mortality patterns have changed in recent years, which was not entirely unexpected because there's a strong birth cohort effect in colorectal cancer trends. And rates in people in their early 50s have been increasing since the mid-90s. From 2011 to 2016, incidence rates in ages 50 to 64 actually increased by 1% per year, following declines of 2 to 3% per year in the previous decade. And similarly, the decline in mortality rates in this age group has slowed from about 3% per year to just 0.6% per year in the most recent data. These changes reflect generations of individuals who first experienced excess risk of colorectal cancer and are carrying that with them as they age. Rising incidence in young age groups coinciding with declining rates in older individuals is rapidly changing the face of this patient population, with the median age at diagnosis dropping from 72 to 66 in less than 2 decades, supporting the move to a younger screening age from 50 to 45 for all individuals at average risk, which is what the ACS recently recommended in their guideline update in 2018. The next few slides characterize recent incidence patterns among those under 50 nationally, with this one showing trends by anatomic subsite. A new finding in these data was that during the most recent 5 years, which is 2012 to 2016, incidence rates increased by about 2% per year for tumors in the proximal colon, as well as those in the distal colon and rectum. And this is really contrast with earlier years when the increase in early onset disease was purely driven by rectal tumors, as you can notice from the steeper overall slope on this right-hand panel. This figure shows trends by stage at diagnosis. Over the past decade, rising incidence has been confined to regional and distant stage disease, while rates of localized stage disease have remained stable since 2006. And this further establishes late-stage diagnosis as a hallmark of early onset colorectal cancer patients, and also highlights the opportunity, the potential opportunity for earlier diagnosis through screening, because almost half of patients under 50 are ages 45 to 49, and so thus could potentially benefit from screening at 45. Trends in early onset disease also differ by racial and ethnic group, which is of course relevant for state burdens because of demographic differences. Among the minority groups shown here, there's been a small but statistically significant increase for colorectal cancer overall in Blacks and Asian and Pacific Islanders, although these increases are confined to rectal tumors. Rates of colon cancer in Blacks and Asian and Pacific Islanders under 50 remains stable. And among Hispanics, rates, the APC is fairly large, but it's non-significant at this point for colorectal cancer overall, although interestingly for colon and rectal cancer both, there's a significant increase among Hispanics. So I think this is just really a function of joint point. The most rapid increases, however, are among non-Hispanic whites and American Indians and Alaska Natives, who we know have an extremely high burden of colorectal cancer already. Over the past 2 decades, rates have increased by about 2% per year in both of these groups. We recently wondered whether there are also geographic differences in incidence trends, and published a paper last year looking at changes in incidence for early onset disease by state, and state trends are mostly stable for Blacks and Hispanics, but increasing among whites in 40 of 47 states in that paper, which are mapped here with the largest annual percent change over the past decade shown in dark blue. States that had stable rates are in gray, and there were no declining trends. And the steepest increases were in Western states, which was surprising because these states have lower prevalence of colorectal cancer risk factors like obesity and smoking. However, in the Southeast, where we're focused today, West Virginia also had among the steepest increase at 3.6% per year. In contrast to other states in the Southeast, Mississippi and South Carolina were among the 7 where rates were stable. However, like most of the stable states, South Carolina had a positive APC that was non-significant. So I had a hunch that it might change with an additional year of data. And in fact, it did. So when I updated the 7 states that were stable, both South Carolina and Hawaii now show a statistically significant increase, whereas Mississippi remains stable. So now we have 42 of 47 states with an increasing trend in whites, including 11 of the 12 states in the Southeast. This figure shows the trend in rates among non-Hispanic whites in the 12 Southeastern states combined in dark blue versus other US states in light blue since 2004, so that I could include all 12 Southeastern states. And with the addition of non-Hispanic Blacks in red, you'll notice that the racial gap in the Southeast has closed in these few years as a result of a slight decline in rates in Blacks coupled with the increase in whites. In 2004, rates were 30% higher in Blacks than in whites in the Southeast, and in the past couple of years, they've been the same. Contemporary incidence rates for all races combined are highest in the South and lowest in the West, in contrast to the change to the trend patterns that I just showed. And this is the same for non-Hispanic whites, which are shown here. And this mirrors the pattern that you'd see in a map for older individuals and reflects the prevalence of, again, of known risk factors like obesity and smoking, which are highest in the South. Rates for all races combined in Southeastern states shown here range widely from 10.8 per 100,000 in Virginia, which is slightly lower than the rate for all non-Southeastern states combined, shown in gray, to 14.5 or higher in Kentucky, Mississippi, Arkansas, and Alabama. And mortality rates range in these states from 2.9 in Virginia and Florida to 4.1 in Mississippi, with states ranking similar to incidence except for Kentucky, which leads in incidence but falls to 5th in mortality. Of course, because of population differences, states rank differently in terms of the burden of disease. This slide shows the estimated numbers of new colorectal cancer cases and deaths under age 50 expected in 2020. And Florida has by far the largest number of both cases and deaths, despite having among the lowest incidence and mortality rates. And this slide shows the expected number of total cases in the Southeast in 2020. We're expecting about 5,000 new cases of early onset disease and more than 800 deaths. And this is disproportionate. The Southeast is disproportionately represented among early onset patients because these states as a whole account for 25% of the US population, but 28% of early onset cases and 29% of deaths. In the US overall, we're expecting about 18,000 new cases under 50 this year and more than 3,600 deaths. Earlier, I showed that increasing rates are combined to advanced stage disease, and this bar chart shows how the stage distribution in early onset patients compares to those 50 and over. The younger patients are in red and the older patients are in blue. Young patients are much more likely to be diagnosed at an advanced stage, with 1 in 4 diagnosed with metastatic disease compared to 1 in 5 patients 50 and older. And of course, this is largely because of screening in older adults. However, young patients are 40% more likely to be diagnosed with advanced stage disease even after accounting for screening, largely because of avoidable delays in diagnosis. For example, one study found a median time of from onset of symptoms of rectal cancer to treatment of 217 days for patients under 50 versus 29.5 for those over 50. The largest factor contributing to this disparity is a longer time between onset of symptoms and initial provider visit among young patients. So there's an opportunity here to increase awareness of symptoms and shift these diagnoses earlier. And I think also a factor is related to the stigma of the disease. And these delays in diagnosis, of course, have a big impact on outcomes. The 5-year survival rate drops steeply from 78% for young patients diagnosed with regional stage to 21% for distant stage. And a recent study estimated that 40% of colorectal cancer deaths could be averted with a shift from stage 4 to stage 3 diagnoses. I've already pointed out some obvious opportunities where screening could help, but let's look at that in a little bit more detail. So again, I already showed this, but I think it's worth reiterating that half of early onset patients are ages 45 to 49 and could benefit from screening at 45. Approximately 30% of these patients have inherited excess risk and should begin at 40 or even younger. And this study that was published a couple of months ago looked at colorectal cancer patients in their 40s who met criteria for early screening and found that 98% could have been diagnosed earlier, and in some cases possibly even prevented if they'd been screened according to guidelines. For people at average risk, there's still a lot of controversy about when to begin screening, but data that's been accumulating since the ACS recommendation came out in 2018, including some of the data that I've shared today, seems to support beginning at 45. For example, this study by Ladebom and colleagues found that screening initiation at 45 instead of 50 is cost effective. And this study by Jordan and colleagues found that by looking at single year of age incidence, there's a very large pre-symptomatic case burden detected around age 50 when people begin screening that could be detected earlier, and some may be even prevented with screening beginning at 45 or earlier for those with familial risk. And this is especially pertinent given the recent uptick in people over 50 now, 50 to 64 that I showed earlier. And then this study on colonoscopy outcomes from the New Hampshire Colonoscopy Registry that was presented at ACG. Some of you may have seen this, and the study is actually currently in press, found that among an average risk population, the prevalence of advanced colorectal neoplasia in ages 45 to 49 is the same as that in ages 50 to 54, as is the prevalence of clinically significant serrated polyps. I know you're all very familiar with this map, which shows up-to-date screening among those 50 and older in the US. The darkest shade states shows the lowest rates, but I thought it's an important point to highlight the large variation. Prevalence ranges from 60% in Wyoming to 76% in Massachusetts, and is about 70% in southeastern states, except for West Virginia, Arkansas, and Mississippi. Mississippi with the lowest rate in the southeast of 64%. And notably, Mississippi has the highest colorectal cancer mortality rate for all ages combined, as well as for those under 50. Unfortunately, BRFSS, which is our source for state data, doesn't have information on screening under age 50, but nationally about 21% of people age 45 to 49 were up to date for screening in 2018. But we can look at screening prevalence in ages 50 to 54, which is a very important group to target because their rates are so much lower and there's more state variation. And of course, both incidence and mortality in people in this age group are increasing. Among those in their early 50s, up-to-date screening ranges from 41% in the western states of Wyoming, Nevada, and New Mexico to 62% in Hawaii and Connecticut. But screening in this age group is less than 50% in almost half of states. In southeastern states, which are shown here in red, screening in 50 to 54 ranges from 43% in Mississippi to 54% in Kentucky. It's nice to see Kentucky leading the Southeast because they have the highest incidence rates, not only in the Southeast, but in the entire US, both overall and in those under 50, although Whitney might dispute this with me. Of course, alongside Mississippi, who again brings up the rear in screening in the region. In summary, progress in reducing colorectal cancer incidence is now confined to people 65 and older, as the new data show increasing incidence rates in 50 to 64, as well as a big slowdown in mortality declines. And these oppositional trends are causing a rapid shift to a younger patient population for colorectal cancer. The Southeast has a disproportionate number of cases and deaths under 50, and rates are increasing in whites in most states, in contrast with fairly stable rates so far in blacks, although I have a feeling this may change. Early onset colorectal cancer is characterized by advanced disease, largely because of avoidable delays in diagnosis, as well as low rates of screening. That will, and all of this will likely be exacerbated, as we've heard in the earlier presentations, by the pandemic. About half of patients under 50 are age 45 to 49 and could benefit from screening at 45, or even earlier for those with familial risk. And although the absolute risk of diagnosis under 50 remains low, the burden is substantial and growing, with 18,000 new cases in the US this year, including 5,000 in the southeastern states alone. So what can we do about this while we're waiting for research to uncover the cause? And I think there is a lot that can be done to mitigate the burden that we can do right now in terms of risk factors. The patterns for early onset disease geographically are the same as those among older adults, which suggests that healthier lifestyles could reduce the burden. In addition, more screening could potentially prevent some of these cancers, or at least detect them earlier. And accumulating data supports average risk screening at 45. I'm a little biased on this, but it seems clear to me that this could help, because it could benefit half of early onset patients. Screening should occur even earlier for the 30% of young patients with familial risk, but this isn't happening either. And I think this has been mentioned as well, but the challenge, of course, is to increase awareness about the importance of family history, both and earlier diagnosis could also be facilitated through campaigns, not only to increase awareness about symptoms of colorectal cancer among young people, but to destigmatize the disease. I'm sure you're probably aware the Colorectal Cancer has a really great survey that they publish every year. From that just came out, only 14% of early onset patients were aware of symptoms of colorectal cancer prior to their diagnosis. So campaigns to increase awareness of symptoms would be something that we could do now that I think could really benefit. In the same survey, less than a third of patients were provided information about fertility preservation, which is shocking to me. So I think more holistic treatment approaches, realizing that patients are younger and they have different needs, and just providing more information. The biggest gap that's been reported in the care of patients under 50 is a lack of information. And these young adults are used to having information at their fingertips, but I don't feel like they have that when they're going through this cancer diagnosis. And this could be an easy problem to fix. And that's all I have. Thank you.
Thank you so much, Rebecca. We do already have a question in the Q&A.
Okay. Let me see.
It's from James Allison. Do you want me to read it?
Sure.
Oh, and it just disappeared. Hold on.
I can try to look at these. Let's see.
Oh no. Well, that one has disappeared.
Let's see. There we go.
That's not where it was. Here we go. Despite heroic efforts by the NCCRT and other organizations to increase screening rates over the last 8 years have been modest at best. University medical centers until recently only offered colonoscopy as a screening choice for patients. I'm impressed with the new data, including Yuri's cost-effectiveness studies. How can we afford to fill the gap in those 50 and older if we increase the need for screening in age 45 to 50? What tests should we be recommending considering the serious state of our economy with little hope for a quick fix?
So I think as Erica mentioned, it's really important to realize that when we say colorectal cancer screening, we're not saying colonoscopy. I mean, so, and we know that when people are offered different tests, they're more likely to be screened if they have a choice and they can act on their choice. So I think there should be more emphasis on stool tests for all patients, actually, but especially for young patients because they are at lower risk. So just getting just getting regular stool testing on people starting at 45, I think could be huge. And it would not take resources away, because we certainly don't want to do that, take resources away from people who are older and do have higher rates. But I don't think we have to do either or. I think we can do both.
And then we have a question from Grace.
Yeah, I was reading this. So this is about risk factors, and unfortunately, you know, the jury's still out on that. Almost all of the studies that have been done on risk factors, and there's a lot of data on risk factors for colorectal cancer, but it's all based on older cohorts. And so because the incidence patterns are very similar, we can assume that there's a lot of overlap, if not 100% overlap, but that's not to say that a known risk factor, something that's already established now, is causing this emerging trend that we're seeing. So it could be, and it does seem like it could be a new exposure, because we see the changing pattern in people born around after the 1950s. And so it does seem as though some new exposure is, or not necessarily a new exposure, changes in risk factor exposures are causing this trend. But I mean, it's just going to take a lot of time, and it's a rare occurrence, so it's difficult to study. There aren't a lot of established cohorts that have young adults. And so this is going to take, I think, some time to figure out.
And all panelists feel free to chime in. I think that is the last question we have currently.
Well,
thank you so much, Rebecca. And
Rebecca,
then
can you hear
Whitney.
me?
Yes.
Yeah, Rebecca, listen, I just want to thank you so much for taking your presentation, which, you know, is spectacular, and really tailoring it to the problems of the Southeast. You know, as a clinician, I have no doubt that part of the burden of colorectal, excuse me, cancer in the Southeast starts in this younger population. And that, you know, our philosophy of using 50 as the starting point for the process of preventing colon cancer has been great, but we need to rethink it. Mm-hmm. Really 45 or 50, depending on which side you live in, really needs to be the finish line for that screening discussion and obtaining that family history. And so I think everyone in the Southeast out there, the 162 folks with us still, really should go back over your slides and figure out where they are and how we should do this. And here's my question, are we going to address this more aggressively before we understand it? Or are we going to go the old way, we're waiting on the answer before we mitigate it? Your mitigation slides were so spot on. What's it going to take to move American medicine before we know the answer?
I think increasing awareness is a big issue, because while this topic is in the forefront for me, every day I learn about, you know, people who have no idea that this is happening. And in that same survey, I think it was around 60% of patients under 50 did not realize that they could even get colorectal cancer. You know, they thought it was an old person's disease and that they weren't even at risk. So I just think there's so much that needs to be done in terms of increasing awareness among the general population, among primary care physicians, just basic stuff, right? I mean, this is not rocket science. And in terms of treatment, it just seems like there's so much falling through the crack with treating these young patients. That just seems, to me as an outsider, it just seems obvious. So I think it's going to take advocacy organizations like, you know, all the great ones that are doing a lot of work on this issue to help increase awareness and, you know, the importance of family history. I mean, there's just so much that could be done now.
So we don't need to wait to understand why to act now.
Definitely not.
Super. Thank you so much. That was a great presentation.
Oh, thank you.
Thank you. Thank you so much, Rebecca. Our next speaker is Dr. Whitney Jones, founder of the Colon Cancer Prevention Project, advocate, change maker, and now retiree. Even though that's really true.
Well, yeah, I don't know about that. Well, the good news is, the bad news is my tech left me, and the good news is he went to work. So that's that's a little good and a little bad. So let me see if I can get in here for my screen share. There we go. You guys see that okay?
Yes.
Amanda, is it okay? You hear me? Well, thanks everybody out there and all the guys who are hanging on. This has been a great day. I mean, we really expected to have all of you guys in Louisville and setting up our drinks and our dinner and all the other fun stuff that goes along with being in our state. But it's great to have you here working. So I've been charged today to talk about shaping policy in the Southeast. And there have been several questions in the chat box about, you know, what's going on at the national level. And I think from a policy standpoint, what we'll see is a lot of the policies that we're looking for to change are happening in the Southeast. So from that standpoint, you know, I'm tickled pink with where we are. So let me advance here. So these are my disclosures. I work with Myriad Genetics, Pfizer, and Exact Sciences as speakers and consultants. But policy and change are really interesting because you don't have to write a law to work on policy. I think that's a big misnomer. Policy really equals engagement for the people who hold the purse strings, as well as a lot of the regulations around what we do. And it comes in terms of not just laws, which we would call legislation, but also appropriations and executive actions. And as part of that, you're going to have to learn to deal with the three most important parts of our bureaucracy. And unfortunately, the judiciary is not one of them. But that's the legislative branch, the executive branch, and then the bureaucracy that actually executes the laws. And this is our State Center for Medicaid, Family, and Health Services over here, where a lot of our great colleagues work in Kentucky. These were our guiding principles. What we did was we only chose evidence-based information that was operational, that was pragmatic, that had a high probability of success. And we think the state level is important because it's achievable and accessible, and you can begin to build momentum once you develop relationships. We used a 501c3 and we hired a lobbyist and developed a team. But I will tell you, just north of us in Indiana, the ACS did a great job with a couple of cancer survivors and switched that state to 45 in 3 months. So if you think you can't do it in your state, study the lesson of Indiana. The important thing, because a lot of you guys work in state consortiums and other things, is who can lobby. And what we found out is that most people who work for state or federal institutions are not allowed to lobby because of their position. They can lobby as an individual, but they can't lobby on behalf of their organization. But they can inform and support the work that we did. So really critical if you're going to get into legislation and lobbying, understand how to put your entire team to work. So you have to identify a bill sponsor, and you might have the person who wants to do it the most, but maybe the entire Senate and House hate him so much that he's probably not going to be your best option. So you've got to find someone who believes in your cause and who also can serve as a bridge into the executive branch and other lawmakers. Then you have to write the bill, review it with those who will affect. And this means sitting down with some very uncomfortable talks with insurers and hospitals and other things who might have a perceived threat. And what we know is that all insurers hate any mandate whatsoever, but they're not necessarily in the point where they're going to get up and testify about it. But having these conversations in advance sort of exposes everyone and lets their positions get on the table. So it leads to negotiation, because this is the time, if there's a particular piece in it that they may not like, you can go ahead and negotiate that without reducing it. Then finally, you gather support, you target decision makers, co-sponsors for bills. One thing about government and lobbying, it is competitive. It's not a round table. You know, this is not a kumbaya moment. There's a lot of other people working to get the attention of those people. And so it's important that you know that that is there. There's a timeline and there's hard deadlines. Once you get there, you got to maintain and support and follow up. And on your slide, you can see our current governor, Beshear, up there talking about flattening the curve. But just before him, we had a reactionary fellow named Bevin who you know, probably actually he vetoed our funding for our colon cancer screening bill. So we've butted heads a few times, but you never know who it's going to be in the next cycle. So again, sustainability and being proactive is critical. So here's our rates in Kentucky, and I think this one shows us at 70.1%, but what you can see here is that we're flattening out, whether it's 69% or 70, we're flattening out because we're starting to reach the highest, most difficult level of people to screen, the uninsured, those on traditional Medicaid, and those that just don't see physicians. So the next slides are going to talk about what we've done in the state of Kentucky before we sort of shift into the Southeast piece. So again, I've got a timeline 2007 on the bottom to 20. These are laws, appropriations, which means money, and then executive actions that just required the chief executive to move on that in that particular piece. So we started off, and Rebecca, you'll be happy with this, because all we really wanted to change when we started was to not get an F on the American Cancer Society report card. So that actually led us in, and I had just been in New York where I was inspired by their public health system. And so our first bill actually mandated that insurers cover colorectal cancer screening, but we also created a screening program for the uninsured, and critically, an advisory committee that oversaw that screening program. We had no money or funds at that time because that was 2008. It was the middle of the Great Recession, but the advisory committee really was critical, and I'll talk more about that in detail. The next things we did were try to get some money, and our great lobbyist Jason Baird found some coal severance dollars. These were tax dollars in Eastern Kentucky, and because the burden was so high over there, he was able to convince them to put some of those funds towards colorectal cancer screening. In 2012, several of us formed a nonprofit organization to develop a public-private partnership called the Kentucky Cancer Foundation, where we raised $500,000 the first year and almost $1 million overall to match funds that were eventually put into the state by the legislature. Governor Bevin vetoed that in 2016 and vetoed it again in 2018. But because of our work in the Senate and the House, we overrode those vetoes to get that $1 million in funding every 2 years. So the other key piece here is Medicaid, and I know this from Jim Allison and the guys out in California, sometimes feels like it's your opponent rather than your partner. And so very early on, we recognized that engaging with our Medicaid department was important because they oversaw the managed Medicaid organizations, and really understanding how to interact with those is key. And we were able to add colorectal cancer screening as one of the 8 quality metrics that these folks had to follow in order to get their reimbursement levels up. And again, that was just an executive action, no legislation required there. As we began to move on, and I was inspired by our issues with regards to the other things, we eventually changed some of the other laws. But what happened in 2014 was the mother of all policy, which was Medicaid expansion. And Kentucky was one of the states in the Southeast to do this. And this accounted for about a 4 and almost 5% increase in our state's overall colorectal cancer screening rate, because the folks who took advantage of Medicaid expansion were ready for it. And our expenditures went from about $6 million to $18 million over 3 years for colon cancer screening. So it was an amazing improvement in that. The most difficult to reach in Medicaid are traditional Medicaid patients who are not part of this. And so that's really one of the challenges we continue to face. The polyp loophole and some of the coding issues were next for us. We got rid of the polyp loophole, where I call it the bait and switch. I like loopholes personally, but this was the bait and switch, where you came in for your screening colonoscopy, they found a polyp, and who knows, all your cost sharing was gone and you had to pay. The other thing we did, as inspired by Jim Allison, who switched me from a colonoscopy only doctor to a colonoscopy plus all things under the sun that are evidence-based, was to include colonoscopies after a positive FIT or stool DNA or CT colonography or flexible sigmoidoscopy, that colonoscopy to follow up that first order positive test was to be coded as a completion colonoscopy for screening, not to be mischaracterized as a diagnostic or a therapeutic examination. Because a positive fit just means you have a positive fit. You're more likely, but if you're you should have been asymptomatic in the first place or not even gotten that test. So the next thing we knew is that genetics were going to become a major part of medicine. And we took a couple of years off, but we supported our colleagues to increase the number of genetic counselors available in the state of Kentucky. And what this did was really set the ground, because as genetics become part of cancer treatment, as well as being utilized in the prevention of cancer through identifying folks at higher risk with family histories, this was really critical. And now independent genetic counselors are able to practice in Kentucky and bill independently and not have to be affiliated with the healthcare system. And most of your states out there have a real paucity of genetic counselors to help with this newer revolution as we go into utilizing genomics and proteomics. And then finally, this past year, we became the first state to pass what we call the Access and Awareness to Genetics Testing Act, which essentially normalized all other NCCN guideline cancer issues with the breast and ovarian cancer coverage that occurs because of the Affordable Care Act. So now in Kentucky, if you meet criteria for NCCN, that should be a covered and preventative service. So a lot of work over the last couple of years. And again, here came in that I think my vision is right over all of this. I'm going to switch out of that. There, I can see my host slides. And so this is the Awareness and Access to Genetic Testing Act at the top. So let's talk a little bit about this advisory committee before we move into the Southeast. Ours are, certain people are there because of mandated in the legislation. Others have been added ad hoc because of that. But critically, we see the key people in our team, Medicaid, Public Health, and the Department of Insurance, all being represented here, as well as chosen senators and representatives who also sit on that board. We have our universities, our medical and hospital associations, multiple non-government organizations, 501c3s, and our great Kentucky Cancer Consortium, which is our CDC funded area. And what's critical about this is the senators and representatives are really a lever to encourage the engagement of these key people here with the advisory committee so that we're all pulling in the same direction. You know, if we want information, our guys from Medicaid work extremely hard to get it to us. And if there's any hiccups, you know, a letter from one of our senators or representatives helps to grease the skids for that. And we've met every third Thursday of the month since 2008. We have the best staff in the nation who help us with this. Our goals are to increase colorectal cancer screening rates for all eligible folks. And we oversee the screening program for the uninsured. We do annual reporting to our legislator and the executive branch, and our meetings are open to the public. So this has been a really key part, I think, of Kentucky's success. And I can't thank the people who sit there and work with us monthly. But what I will tell you is even if you pass all these laws that we did, it doesn't mean anything if it doesn't reach the people who it changes. And by that, I mean physicians, coders, hospitals, executives. And in fact, we were made aware in the last year that despite us in the echo chamber knowing all about this, in fact, we weren't seeing a flip of behavior at the clinical level. So just this year, we've done I would call it backfilling up here at the top. That's our backhoe there. And this has been sent to the Kentucky Hospital Association, CMOs, CEOs. We'll be going out to all physicians, and we're working on nurse practitioners as well as any other organizations that we can work with. So again, just because you get the laws passed doesn't mean they're going to be impactful unless you can get this changed. So what about state policy for the Southeast? And again, we'll go through this, but I think some of the ones we've already done are important. Medicaid expansion, but again, you don't have to expand it to interact and integrate with your Medicaid folks in your state government. Again, I'm a big ACS guideline fan. I think 45 is for sure going to come. I'll talk a little bit about that in a second. Funding programs for the uninsured, and in Kentucky, we actually cover the underinsured as well. Closing the polyp, bait and switch loophole, and changing colons. Universal tumor testing for MSI. This is critical for us to identify Lynch syndromes or those who have alternative modalities. A study just came out from UK showing that 42% of people in Kentucky don't get optimized care after their colon cancer diagnosis. And I assume that's going to be the same in a lot of places that have rural or Appalachian areas. So very critical. And again, why in the world should colorectal cancer take a second seat to the important issue of breast and ovarian cancer? Every state ought to have similar coverage for both of those. And finally, again, if you're trying to dip your toes in the water, think about an advisory committee as a first start. So here's our improvements in the Southeast. This is a similar map to the one Dr. Siegel showed. And in the bottom, though, you'll see the Southeast with the improvements between 2012 and 2016. Big shout out to Arkansas here, Kentucky at 6.5, South Carolina, Louisiana, Alabama, lots of improvements going on here. But you'll note that 3 of the 4 top improvers in the Southeast had expanded Medicaid. And one of those, South Carolina, we're not sure exactly what their secret sauce is, but I think it has something to do with these personalities and these pictures of these folks down below. So again, look where you are. And again, I know my friends and colleagues in Georgia have got to be devastated in looking at this number. You know, the Center of the American Cancer Society and the CDC, clearly there's lots of opportunity to make improvements in that state. So this is sort of a wake-up call for where you are and what you need to be looking at. Well, what about medication expansion? You can see here that the Southeast, and again, I want to make sure I include our colleagues in Texas and Florida and Puerto Rico somewhere over here, but doesn't show up on the screen. We did not take advantage of Medicaid expansion for the most part. And again, those states that have improved did. So this is clearly one of the issues that we have to address. And as we move forward in this extremely tumultuous political time, better understand. What about programs from the CDC? The CDC is active very much in the Southeast, with only Georgia, Missouri, Mississippi, North Carolina, Tennessee, Texas not being in the grantee parts, at least for the 1502s. There may be some Screen for Life money there. And also, there's only about 3 states that have funded programs for the uninsured, including Alabama through the Fitway, Kentucky, and South Carolina. So this is one area that I think can be worked on. Again, programs for the uninsured don't have to all be colonoscopy based. Again, I'm a believer in all evidence-based modalities. And so there are possibilities for cost-effective ones. Here again, I think in terms of the CDC, we're relatively well represented compared to the rest of the United States. And I'm shocked that my buddies down here in Texas, and this is my alma mater, UT Southwestern, we didn't see any part of Texas being engaged in that. So we'd love to have our Lone Star guys. In terms of variation by rates and age, Dr. Siegel laid this out. The Southeast has a disproportionate burden of under age 50 colorectal cancer, which I believe is directly relational to the burden that we're seeing in over 50 and overall incidence generally. A lot of this follows the Mississippi River, as you can see, and again, a variety of toxins, behavioral issues, smoking, obesity, sedentary behavior, and diet all play a role. We are certainly hoping to flip some of those issues with other policies, but again, the linkage is there in the Southeast, and I think it's why we've got to continue to focus on this. Well, one of the issues we know that we can help people under 50 is by screening them at 45, and these are the American Cancer Society states in blue, and I got this from the MyCT colonography website. And I was sort of surprised to know that North Carolina, Tennessee, Georgia, and Louisiana follow American Cancer Society guidelines. And so I think it's critical to get active at the state level to make sure that people are aware of that, and that you should be trying to push those issues. And again, we'll know more about 45 versus 50 in 2021 when the USPSTF eventually tells us what we're going to do. So again, you should know your state and know where you're going to be on this. But what we've already found out that there's already a bunch of barriers because we've been pushing this. There's a lot of people who say, I am a USPSTF guy and I'm waiting. I'm not changing anything. This particularly was important with hospital systems that had built-in electronic health records with modules, and they were reluctant to change out of USPSTF for one cancer. And again, in Kentucky, it's ACS for colorectal cancer screening. There's a huge lack of provider and network knowledge about the changes that we made, which is why we're backfilling it. And again, how do we engage our National Association for Community Health Centers, which is critical to begin to really wrap their head around 45 in those states that have that as policy. And finally, you know, again, Louisiana, Georgia, Tennessee, North Carolina, get with your insurers and be pushing this forward. I'm certainly hopeful that we're going to have a confluence of screening ages in 2021 as USPSTF reevaluates. In terms of coding policies, and again, this is a loophole. This is, never saw this, but this is what it is. Really key, and again, this has been going on at the national level for quite some time. It still hasn't made it through the mess that's going on up there. And again, presented in March of 2019, and I think we will again. But again, it may in fact not be the national level for us in the Southeast, at least for some time being. And if you are in the Southeast, the Fight Colorectal Cancer guys here have a Catalyst program. This year it is going to be California, Colorado, Louisiana, Arkansas. So we got 2 of the states. So make sure you reach out to them to help you with funds, lobbying support, and lessons. Don't forget about the future. Genetic testing is critical if we're going to identify people with Lynch syndrome. Right now, we only identify 1 out of 10 with Lynch syndrome prior to their diagnosis of cancer. So that's terrible. That's like landing the plane 1 out of 10 times. So we've got to find a way to benchmark family history much, much earlier in the 30s so that we can identify those folks. 1 out of 5 people should be screened at 40 or earlier. The only way to find that out is by talking to them in their 30s. Genetic testing has to become part of what we do, because if you identify with Lynch, you identify on average 3 other people in their family who you can utilize preventative services for. And finally, as you're thinking about it, make sure you think about shaping the future. You don't want to be a dinosaur over here. The way we like to think about it is going from defense to offense and utilizing new technology as part of that. And again, I think we're in a binary world when we only talk about colonoscopy and FIT. We're going to be seeing lots of new tests coming on board, and that'll be one of our focuses next year at our in-person conference. Family and hereditary risk is critical. We mention it every time, but it always gets lost in the noise. We've got to find a way to benchmark acquisition of family history with appropriate evidence-based reaction to it. The early age onset colorectal cancer focus is going to continue. Let's not forget about weight, diet, exercise, and smoking. These are in everybody's silo, so we should combine on that. And maybe we're going to need new technology. We're going to need AI. I sort of can't believe that we're not using databases for insurance companies, hospital systems to identify those people who've never been screened and reach out and communicate to them, hey, you haven't been screened. Having to wait for a patient to go through a portal to see one doctor, even in the electronic health world, seems antiquated to me. We ought to be making sure that people know in advance of their birthday. And finally, I'm a big proponent of advancing prevention through early messaging and on-time screening. I think it's the key for us to be on board. On-time screening works better than late screening. And who's going to show up for this webinar if I had sent out the invitation at 1 o'clock today? The answer is no one. So let's try to align medicine a little bit with what happens in our real world in terms of communication. Now, we've been here looking at the curves and the mitigation, and we've been through the COVID. I can tell you that my one lesson and take home from COVID has been that I really want the people in charge to be thinking about how to prevent things from happening, not just reacting to them. And here you can see the current incidence of colorectal cancer in black and the current mortality in blue. And I think we have got to get aggressive about how we are going to flatten the curve, how we're going to mitigate these issues. And again, imagine if we were able to push down incidence with on-time screening at 40 and for high risk and 45 for non. And look what would happen to mortality. And these are just creative things that I'm thinking about in terms of brainstorming. I think that we should all be thinking about how we do this. And I mean dramatically, because we have the nation's highest burden of colorectal cancer in the Southeast. So what does that lead to? An invitation to the next seminar, which is going to be next year. And again, we don't have the specific date, but it'll be June 21. We're going to talk again about health equity and literacy. We're going to continue to focus on colorectal cancer. Part of what we didn't get to do here was emerging technologies and new strategies, policy-driven opportunities again, and who knows what will change, and the impact of COVID on all things colorectal cancer. And your suggestions are welcome. So again, health equity and literacy. Appalachia is this huge area that runs down the United States, actually all the way from Maine to Florida or Georgia, but we've still not been able to solve this puzzle. And it's poverty and education, as we know. The southern regions, Florida, Texas, Puerto Rico, African Americans, Latinos, and Hispanics. And I think one of the biggest health equity issues is men. Men are screened at a lower rate. Men have higher rates of incidence and mortality. How are we going to address those to try to get people back here? Because I know we like men and as well as women, so we got to focus. This is a slide. I want to shout out Tom Tucker, who got to me. This is what this is a slide that looks at the age-adjusted incidence rates of colorectal cancer in patients 20 to 49 versus those in the other states in the country. So this is early age onset colon cancer. In the red is Kentucky, and the blue is the rest of the nation with Kentucky pulled out. And again, because the numbers are small in Kentucky, there's a lot of erratic issues. But what you can tell here is that Kentucky has been and continues to be above the nation in early age onset colon cancer. In many of the states out there listening, that's the same thing that's going on where you live. And the problem is that it is a diverging trend, not a converging trend, meaning this is only getting worse for us in Kentucky. So again, for us, 45 is the finish line for communication, not the starting point. And again, we're going to continue to work, and we've got some great folks on our team to begin to understand better how data can shape our reactions and our proactive approach to it rather than just looking into the past. Early age onset colon cancer, a top priority. Earlier messaging, family cancer collection, genetic testing. How do we identify, then screen the high-risk populations? How do we get the sporadic folks to know the symptoms? Because they're not going to have a family history. And then finally, treatment issues. This is a favorite slide. It says, tell him we don't have any time for his bright ideas. We've got a battle on our hands. And the machine gun sitting here ignored. And one of our big focuses is going to be technology and innovation. I'm sorry we didn't have time today to go into it, but I think we've got to break out of the two-test paradigm. We've got to understand how stool DNA fits in here. There's the test, but more importantly, there's the program, which is how we actually save lives. Is there going to be a role for stool DNA in public health? We just approved it in Kentucky as part of our offering. Emerging screening issues, blood, liquid biopsies, urine, imaging studies. Got a couple of questions about CT colonography. CT colonography is a great test. It's just underutilized now. MSI for colorectal cancer, not happening in about 70% of places. So we're not even looking for Lynch syndrome or using genetics and tumor genetics to drive our treatment issues. We've got to do better than that. Advancing treatment, making better use of big data. And is it time for us to call in artificial intelligence for us to throw in the towel? I hope not, but we could certainly use them on our team. And finally, we'll focus on policy and promise. In 2021, the USPSTF will come out with their guidelines. I fully expect and hope that they will switch to 45. And if our biggest issue is how are we going to screen the 45 to 49s because we're not doing a good job in the 50 and aboves, happy to have that dialogue. And again, will new tests be approved there? And again, we're going to have to rethink colorectal cancer, and COVID, as has been said several times before, has accelerated it, not given us new things, but made us think differently. What are the implications of the 2020 election on federal policy, health insurance, Medicaid expansion? Unbelievable. And I got a picture of the Cheeto president here for everyone. So we shall see. We'll update what's going on in state-based issues, and we'll talk about the expansion. And again, make sure we don't forget COVID. So thanks to everyone, particularly our generous sponsors and supporters. I also want to thank our speakers who were signed up and we had to delay. We certainly want to see everybody in beautiful Louisville along our walking bridge with our city in the background. I want to thank the staff of the Colon Cancer Prevention Project and Surgery on Sundays for our planning committee and all of the assistance we got from people who've previously held this, particularly the folks in South Carolina who've just been great, who actually, sort of founded this. So we call this the 4.5 Southeast Symposium. And if you don't see a topic that I have there that needs covering, let me know and let Amanda Smart know for us. So we are tickled pink to have you here today and joining us. We look forward to next year and going over the improvements. So don't forget, observe, orient, and decide, but action is the key for us to get back to it. So that's it. I want to appreciate everything. And Amanda, I'm happy to take some questions and go from there.
Absolutely. And everybody that asked, we will be sending a recording of this out in the next week. And if we do get permission to send PowerPoints out, we will do that as well. So let's go ahead and check our question. Beth McFarland asked you a question. I think you just addressed it. ACR has a website which shows reimbursement for CT colonography. Most private payers for CTC screening. Medicare does still not pay for CTC screening, but does pay for diagnostic CTC after incomplete colonoscopy in patients at risk to undergo OC.
Yeah, well, I think that CT colonography is a great test. I think it's underutilized. I think some of that has been the places that do it really, really well do a lot of it. And I think if you're doing it in small increments, I think there's a tendency for radiologists to, want to be defensive in their call. But I think it should expand, and I think it's a great test. And I think this is one place where artificial intelligence can really play a role, where it actually helps the physicians identify abnormalities. So I fully support CT colonography. I think it's great.
Okay, let's see. And you did mention Cologuard, but Grace asked, why not pass out Cologuard or some other at-home screening modality for the economically disparate?
Well, I mean, I think that my own vision is that in a decade, all stool testing will include a DNA component. If we're still there. So I think it would be part of it. I think that the issue with FIT testing as well as stool DNA testing is that if you're going to hand out these first order tests, it's critical that you make sure that a positive test is then followed up for a completion colonoscopy screening. And that it's not a diagnostic and it's not a therapeutic. It's completion of the screening program. And I think the issues with any of these things that you hand out at health fairs and everything like that is, having that person, are they going to react positively when it's positive, or are they going to stick their head in the ground like an ostrich and say, I'm not looking, I'm getting my affairs in order, et cetera, et cetera. What we do know is that it's important that it be offered as part of shared decision-making for asymptomatic normal risk individuals, and that it plays a critical role, particularly in this rethinking of colon cancer. COVID has changed it. We've heard from Dr. Karlitz about what's going on with colonoscopy volumes. I hear the same thing with my colleagues. We cannot let up on colon cancer just because we have to rethink the structure and the operations of how we do it. So I see an ascending role for both FIT and stool DNA in colorectal cancer screening going forward. And I'm hoping we can narrow the gap between gastroenterologists and endoscopy providers and stool DNA and FIT. And I think that, that's normal anytime there's competition amongst tests, but I think that we've got to sort of, slap ourselves in the face a little bit and remember that, you know, the competition here is colorectal cancer. And who wouldn't, if they had a $1 test that you could get in blood every 5 years, recommend for that for their patients if it ever came to be. So we've got to embrace these and we've got to utilize them.
Let me see if there's any other questions. That might be just about it. Let's see. Just some comments here. Melissa made a comment. Patient navigation plays a large role in providing fit kits and other screening.
Yes, I think navigation is key. We know that when we hand them out at health fairs, we don't get 5–10% returned. And, you know, so I just think that we've got to be careful about that. And again, I think the other thing about stool DNA right now is I don't think it's all about the test. I think it's all about the process. And that it isn't just going to be, is the test more sensitive or less specific? It's going to be, do you have navigation embedded there in a way that improves the likelihood of the test getting finished, as well as that colonoscopy for people who are positive. And likewise, the last thing we want to do is have the wrong person getting first order screening tests. We don't want people with family histories of polyps or colorectal cancer. We don't want people who are symptomatic. So that's a real important key. So you're still going to have that piece, but I think we're going to have to, you know, we got to put it on an app. We got to get it in people's hands. We've got to, you know, use some of the telehealth things that Dr. Carlitz spoke about. We can do better than this binary choice and running everyone through a small little gap. And I think that that's where I want to see big data, you know, come in and help us. I don't understand why Blue Cross Blue Shield, as part of the team, doesn't query every person about their colon cancer history and make sure they know at age 45 or 50 that you should be screened, and send something out and even offer them a test. So lots of opportunities is what I think. And I really think we've got, we want to go on offense. We've been playing defense for decades.
All right, we've got a lot of thank yous here, and I want to thank all of our speakers today. You guys did an amazing job, and I'll be sending this out in the next week, and also be looking for an email the next couple of months to announce our new date for our colorectal conference next year in June, most likely, but just stay tuned for that.
Yeah, for sure. And one last thing, Jim Allison had a sheet up there. I know that the study came out about cost, and stool DNA is more expensive. All that's going to come down. There's going to be competition in the market. You know, Jim's been a real leader in teaching us about the other things. I want to back up what Amanda said, and Dion and Dr. Sutton, who along with us organized this and will be heading it up for next year. I can't thank them enough for their hard work and their dedication. I mean, what a great thing to have Jordan Carlitz and Rebecca Siegel as part of your team, looking at how we're going to do it. Because these are the guys for the future. No one more than Jordan's doing it in a great publications. Rebecca's been leading for a long time. We are so lucky in the Southeast to have the team that we've put together. So much so that I know Jim Allison in California, they're soon to have their first California or Western Colon Cancer Coalition, and we'll wish him luck on that. So thank you very much, everybody.
Thank you.
Thanks, everyone. Have a great rest of your week, and I'll be emailing you guys soon.
Great.
Okay.
Stay safe.
Thanks.
Bye.